I wrote to Mary, I said, I honestly don't know what to talk about. And she said, well, our absolute dream talk, and I will tell you what test do I order. And this is, of course, an issue for clinicians of all stripes, and said that we order a lot of tests, the renal bladder ultrasound and CTU being our best friends, but outside of stones and hematuria, sometimes things are confusing. When is MR better than CT to perform? Should we give patients contrast? Many patients cannot get contrast. Should we do a study with contrast, without contrast? Do we always need the abdomen and pelvis? And when can we substitute studies? So hopefully we'll get through all of this, and I'll be able to answer some of your questions. So we will discuss some imaging for common problems and that you will be encountering as advanced practitioners in a urology clinic. And I do have my, it should be Ramchandani 4, and there is a D missing there. So Mary will be able to share my email with you if you have questions. So the contrast agents for urologic imaging are the most commonly used contrast, of course, are water-soluble, non-ionic contrast. I just wanted to caution you about the use of the term contrast dye. Here is a picture of a bottle of IsoView, which is one of the contrasts used very commonly in the University of Pennsylvania health system. You can see it's a clear liquid. And patients are often pretty freaked out when they come because they ask me if their skin will turn a different color because of the dye. And what I have to tell them is that no, it's only called a dye because it shows up on images. It's a clear liquid, and I will often show them the bottle that we are injecting. So if you call it just an X-ray contrast or radiographic contrast, that might be a slightly less confusing term for patients. There are two main kinds of contrast that your patients will be receiving for radiology studies. One is the iodinated contrast, and basically it is the iodine molecule in these contrasts which makes things show up, it causes radiopacity. And then, of course, we have the MR contrast, which are all gadolinium-based. Iodinated contrast, it's pretty much the same contrast used for all studies, whether we use it for intravenously for CAT scans, the rare intravenous urogram or intravenous pyelogram, for renal arteriograms, for CT angiograms of other kinds, or for VCUGs and cystograms. The only difference is that the concentration of the contrast might be different for the different studies. MR contrast pretty much are all gadolinium-based. The low osmolarity contrast or non-ionic contrast are pretty much universally used throughout the world at this point. This shift really occurred in about the early 2000s. There are many, many brands, and the brand that your particular institution uses would be dependent on the contracts that they have with the different manufacturers. So these are some of the different varieties of contrast that are available. In the Penn system, we tend to use the iopamidol most frequently, with the others being used less frequently. So let's talk a little bit about adverse reactions to contrast. So these fall into two main categories. The most important one that you will hear about with patients being particularly concerned is the so-called allergic reaction. It's important to remember that these are allergic-like or anaphylactoid-like. These are not real allergies. No antibodies have ever been found to contrast in people who have had an adverse reaction to it. You do not really require a prior exposure to contrast to get a severe reaction, and the mechanism for reaction is not understood. So this is why these are referred to as anaphylactoid rather than an allergic reaction. The non-idiosyncratic reactions are related to the chemical structure of the contrast, and these are the physiologic effects that the contrast has on the different body organ systems. Most acute adverse reactions to contrast are very minor, and they will affect about less than 5% of patients. Severe reactions where your patients are going to require to be hospitalized to deal with the contrast reaction are extremely unusual. Fatal reactions have been described, but again, not a common problem. So many patients who do develop these reactions will have urticaria, diffuse rashes. They may develop laryngeal or upper airway edema, bronchospasm. It's a pretty frightening thing to have happen when it does, hypotension. So whenever we inject contrast, we do watch these patients, but as I said, reactions are very unusual. What is the significance once a patient gives you this history, or in a radiology department this is recognized, where we make sure that this gets entered into all of the electronic medical records, that the referring provider, you guys, know that this happened to the patient, and such a patient, if they require contrast in the future for another radiology study, really should get a steroid prep. Okay, so all these reactions, nearly all of them, will begin within 20 minutes of the contrast being injected, which is a good thing. So they're usually in the radiology department still being, finishing up their exam or halfway through the exam when the reactions start, so we are able to deal with it. And most patients will respond quite nicely to fluids and epinephrine and other acute maneuvers to deal with the contrast reaction. One thing that I do want you all to keep in mind, unlike bee stings and other allergies where you can give a little test reaction to see if someone is allergic to it, this does not apply to contrast at all. As we said, we don't really understand how these reactions occur, but what has been found is that people, that even a small so-called test dose can result in anaphylaxis. So that is not a helpful way to figure out whether someone's going to have a bad reaction or not. So how do you prevent this? There are two mainstays. One is steroids to stabilize cell membranes, block complement activation, stop the cascade of for anaphylaxis, and the other is basically antihistamines, Benadryl or some other diphenhydramine. So the pre-medication regimens, almost all of them will combine a steroid and a H1 antihistamine. Ideally, this regimen should be started 12 hours before the anticipated contrast administration. And so one typical regimen that we use at Penn is 50 milligrams of prednisone, 12, 6, and 1 hour before the exam. If there is a patient who requires an emergent study and has a bona fide history of contrast allergy, then we can give them IV hydrocortisone, stat, and then every 4 hours till the exam is complete. If the patient has received Benadryl, you do want to caution them about driving.